Third time's a charm. Hope you guys haven't gotten too frustrated yet. It is late at night, right? Hopefully we all have a great attention span at 8 o'clock at night after a day of work and maybe being with our kids in the afternoon. But we're still on this first slide. We're still looking at Tyler. We're looking at all the improvements he made, corrections to his speech, corrections to his swallowing, corrections to the resting posture of his tongue. Clearly, per the graduated picture on the right, his tongue lives now in the roof of his mouth, and he is not squishing his tongue between his teeth, causing an open bite. He has better health. And one thing that I want to mention that I think is really, really interesting is that when Tyler was younger, when he was about 6 or 7 years old, he went to speech therapy for 2 years, okay? He went to speech therapy for 2 years where they corrected his S sound. And then by the time that they came to see me, I said, that's terrific. A, he still has a lisp, but B, they didn't solve the underlying problem, which was his tongue function. So once we worked on the tongue and strengthening it and correcting the posture for rest, for swallow, for speech, then we had success. And we worked in conjunction with a team of orthodontists and ENTs and had ultimate success. So here's a success story right off the bat when we're looking at what myofunctional therapy is.
Dana requested to speak. So just call out Dana and say if she has a question.
Dana, hi. I hear that you have a question. I'm super curious to hear what it is. Go ahead and type it in. And Julie, because I have this team here, this amazing team. I don't know if you heard this. A whole team of people here to help me technically with the webinar. Feel free to type in your question, and I'm happy to answer questions through this entire process. In the meantime, while we're waiting for your question, I'll move on to the next slide so we can keep moving forward. What does myofunctional therapy include? Well, step number one is always, always, always to eliminate oral habits. We must get rid of finger sucking, thumb sucking, nail biting, tongue chewing, lip biting, all these oral habits so that we can get to the next phase, which is to teach people how to breathe through their nose and not their mouth, get correct resting posture of the tongue, get correct chewing and swallowing patterns, and then habituate these good habits. So it's not just they learn them and off they go, but they learn them, they habituate them, and we really make a long-term change. And then, of course, because we are speech therapists, our job, we know this, is to correct the speech sound errors. You will find that there are, and I'll talk more about some of the associations and groups that do myofunctional therapy because it has existed for many years, for 40 or 50 years. But the reason that speech therapists are so well deemed and well targeted to be providing this therapy is because part of myofunctional therapy is correcting speech sound errors. And that's what we do. We already know how to do this. We've been trained to do this since graduate school. So all we need to do is learn how to work with the tongue, work with the muscles of the face, work on swallowing, which again is an area of expertise for us, to get ultimate success for our clients. Let's see if we can, has Dana come up with her question yet?
Not yet.
Okay. Great. So there's a lot of articles out there that talk about myofunctional therapy, and you can find them in the journal or the Academy of Orthodontics. You can find them in different sleeping pediatrician or apnea articles. You can find them in pediatric journals. But this article in 1992, written by Kellum, came out in the Journal for Speech and Language and Hearing Research. And what they did was they took a couple hundred children from a preschool, and they looked at them, and they found that 38% of the children that they evaluated could have orofacial myofunctional disorders, okay? And we'll talk about what those, the variety of those could be. But they also found, and I thought that this was so interesting, that 81% of the children with speech and articulation issues were likely to have a myofunctional disorder. So not only does 38% of your population have OMDs, but 81% of the children with speech issues that we target and we label as a speech issue might have a myofunctional disorder. So we need to look a little further, because if we're treating them just for their articulation issue, like I mentioned about Tyler before, we might be missing the bigger picture. We might be missing the cause of some of these articulation and speech issues. So I'm happy to share that article if anybody wants. You also can look it up and find it. And I have an upcoming seminar in another month, and we have tons more research and bibliographies for y'all to use to read the research. All right, look at my fun pictures here. I try to grab some snapshots of either people that I've worked with, or two, people that I should be working with, or that you should be working with. So what do all these pictures have in common? They all need myofunctional therapy. They are all different presentations of orofacial myofunctional disorders. Up in the upper left-hand corner is my little friend, a thumb sucker. And what I want you to take note of is that while it's so cute when it's younger, prolonged thumb or finger sucking really wreaks havoc on the face. It wreaks havoc on your growth and development of your jaw, of your face, and can lead to later problems down the line. So while it might be cute in utero and it might be cute in preschool, very quickly it becomes a problem that can lead to longer term issues. And one thing I want you to really take note of is that while her little finger is pushing up on the palate, that tongue is resting right below it, low and forward in the mouth. And if you can imagine years of pushing up on the palate and training the tongue to be down and forward, that tongue learns the wrong patterns, the wrong placement. And so myofunctional therapy first needs to eliminate the habit, and secondly, needs to retrain the tongue its proper place within the mouth. Okay? Prolonged thumb sucking or tongue tie or other issues can lead to our problem with picture number 2. That is an anterior open bite with a forward tongue thrust. And you can imagine if the tongue is constantly pushing forward through the teeth, either during swallowing or during speech, that when that tongue goes away, guess what you're left with? Just an open bite, just the teeth literally being opened up by the tongue pushing with pressure. Something I'm going to say over and over again, you're going to hear me say it till I'm blue in the face, is muscle trumps bone. The muscle always wins. So that's why when we work with our orthodontists, they do a fabulous job of aligning the bone, of aligning the teeth, but they can't control the muscle behind it. And that muscle is small, but it is mighty. It is small relative to the muscles in the body, but it is mighty, and it will push anything out of the way to get through what it wants to get through. In this case, it's the teeth. Over to the right, you see an individual who clearly has low tone, right? In those lips. We've seen these kids. We see them all the time. They are mouth breathers. Their tongue hangs forward through their teeth. Sometimes this is a cause of enlarged tonsils, can be a cause of allergy issues, could be caused by prolonged habits, training the tongue to be down and forward, and creating some mouth breathing. It's kind of this vicious cycle. I want you to think about somebody starting out with a finger habit of thumb sucking. The tongue learns to be down and forward, changes the development and growth of the jaw, trains the person to be a mouth breather. They've pushed up through their nose, so they have less ability to breathe through their nose, so they want to breathe through their mouth. And ultimately, it drags the whole face into a longer face syndrome. So there you can see that progression of cute little thumb sucking that ultimately turns into a long face, open mouth posture breathing with sinus issues and tongue thrust issues. All the way back over to the bottom left, you will see this all the time. Did I say that? You will see this all the time. And it is so vitally important for us to recognize what a short lingual frenulum looks like. And there are different levels. There's different grades of a tongue tie. So I think we're so used to seeing it so severely that the person really can hardly move their tongue and elevate it, protrude it at all. But you could have different grades. Anything under a 50% difference, meaning as wide as you can open your mouth, you measure it, and as wide as you can open your mouth with your tongue touching your alveolar ridge. If it is less than 50%, that is ankyloglossia. That is a short lingual frenulum, and that needs to be referred to an ENT. You know, when we do our therapy, we need to work as a team, and I'm going to talk to you a little bit about who you want to enlist in your team approach. This is an interdisciplinary approach, and you've got to get a good ENT or oral surgeon on your team so that you can make referrals back and forth to each other. So if somebody presents with this, we can get that frenulum, that frenum, clipped, ultimately clipped or cauterized if that's the choice of the doctor, so that the person, the child, the adult can have freedom, range of motion, and less restriction in movement of their tongue. Our little guy in the middle, a Shih Tzu, always has a tongue thrust. You will see them all day long with their tongues hanging out of their mouth. Not much we can do from a myofunctional therapy standpoint on him, but next time you see a little Shih Tzu with his tongue hanging out, you will think tongue thrust, you will think myofunctional therapy, and you will think Simon Says. Over to the right. Yes.
So Angela has a question.
Yes.
She says Ash's position is that tongue tie doesn't affect speech sound productions. What are your thoughts?
Okay, so Angela, right? Yeah. So Angela, that's so funny. I was actually just reading up on that the other day. There is, if you read some of the articles, there is evidence that while a tongue tie might not impact speech sound production, okay? Later, when I see, or even feeding issues early, later when I see these children and they have moderate to severe tongue thrusts, I literally have them lift up their tongue, and 9 times out of 10, they have a short lingual frenulum. So while Asha has to take the position that it is not our job to encourage everybody to get their frenulum clipped, it is our job to identify a short lingual frenulum and send them to an oral surgeon or ENT for follow-up. What I do is I've worked with oral surgeons that believe in myofunctional therapy, and we work together as a team. I have seen drastic differences in individuals who have not had their frenulum clipped and their outcomes versus ones who have and their outcomes. Did that answer your question? Asha's makes statements that it doesn't, I think the comment she said was that it doesn't impact their speech sound production.
Tongue tie doesn't affect speech sound production.
But what it can affect is it can affect their swallowing capability, and it can impact their resting posture of their tongue, which ultimately then can affect their dentition and their malocclusions. And so in myofunctional therapy, I want you to think about 3 areas. I want you to think about resting posture of the tongue. I want you to think about swallowing posture of the tongue, and I want you to think about speech sound production. So we're not just looking at one area, we're looking at all 3. At the beginning of the seminar, I opened up the PowerPoint, and there was a picture of a little girl. And you could see that she had front 4 braces on, and I called her I don't know if you could hear me because there were some sound issues, but I said that she was my poster child for Simon Says recently. Because what this little girl had going on was I ran into her. She was a friend of my daughter's, and I saw her at the mall, and she had a huge open bite. And I had never noticed it so significantly before. And we started talking about orthodontia, and she was going to maybe start getting started with it. And I had her lift up her tongue, and she was I shouldn't say severely, she was moderately restricted. And as I started having more conversations, and I did a full evaluation with her in my office, I came to find out that she had a speech sound error. She had a interdental production of her alveolar sounds. She had a forward anterior lisp, but more, and she had an open bite. We know the open bite was from her tongue sitting right in that open spot. She was a mouth breather. But more than that, the most glaring part of her report and history to me was that she has had chewing and swallowing issues since she was an infant. So she did not have wild success with breastfeeding. She only eats, she has put herself on a modified diet. She has put herself on a soft diet. She'll only eat pastas. She'll eat pureed foods. She cannot eat any proteins that she needs to chew. She occasionally vomits when foods are tough for her to chew and swallow. And those were just such red flags to me that when we went to the oral surgeon, we measured it, we knew it was borderline, but she could protrude her tongue, but when she went to lift her tongue, it went to a total heart shape. Okay, she could not rest her tongue on the roof of her mouth. She could not open her mouth and touch her alveolar ridge. And she now, we did a little preliminary few sessions just to see if we could stretch the frenulum, but she just went 2 weeks ago and got her frenulum clipped. She's had unbelievable success. She says that she feels such freedom in her mouth that I don't think she understood before how restricted she was. I'm actually pulling up a picture right now so that you can see this. I don't know, can you see this, Julie, if I hold this up to the screen? Let me see if oh, here we go. Is that a little bit better? See if you can see that.
It's 30 seconds delayed.
Okay, I'm gonna hold this here so that you can hopefully see it. But over here on the left side, you can see that her tongue looks just like the picture, but maybe a little more so because she has a heart shape. Okay, there we go. Can you see it now? This is before. She has a heart shape of her tongue when she tries to elevate it and lift it. Oh, let me see.
Yeah, I can see it. It's 30 seconds delayed.
There we go. There we go. Then over here on the other side. Oh, I think my light is off.
You can sometimes see it a little.
Okay. On the left-hand side, she has total freedom of her tongue. Oh, thank you. On the left, she has total freedom of her tongue. She's learning how to open her jaw and lift her tongue up to the ridge. You should see this child swallow now. You should see her do some of these exercises, these tongue caves, and you should hear her speech. It is like a totally different kid. Her recovery was 3 days to 4 days long. She had maybe 2 stitches. The surgeon was super pleased. The parents are ecstatic and over the moon. And I can't wait to see this long-term result in just a couple months from now because she's about halfway through the program. So great question, Angela. Thank you so much for asking that. A really good one. So let's move on to talk about some of the different disorders that you might see in your practice. We talked about oral habits of thumb sucking, finger sucking, nail biting, etc. We talked about a tongue thrust, and that is, you know, when your baby is an infant, or if you've worked with infants, when they're learning how to eat cereal, they push that tongue out as they're trying to push the food and the liquid back in their throat. And like at 6 months of age, that reflex goes away, and then our tongue goes into its typical tongue tip up, snake back, swallow. For many people who have either habits or just by virtue of having a tongue thrust, that doesn't change. We see open mouth breathing. We see structural abnormalities, like I talked about, a short lingual frenum. You can also see a short labial frenum up above that upper lip or the bottom lip. And you can see the lingual scalloping where, oh, I think I didn't mention that on that last slide. The child all the way to the right, you can see an imprint of where the tongue rests between the teeth. Improper tongue posture at rest actually makes indentations in the tongue. What's next? Here we go. This is my favorite article to talk about. And I take this with me to every orthodontist that I go meet with, and you will too. In the American Association of Orthodontics back in 2010, Smith, Peter, and a group of other professionals did a study, and they took 130 or 140 individuals, and they had an experimental group that received both orthodontic appliances, meaning braces and so forth, as well as myofunctional therapy. And then they had a control group that only received orthodontic approach alone. And then 3 years later, they looked at the relapse in these individuals. It doesn't get more clear than this. Those that only received orthodontic treatment and had a tongue thrust had 3.4 millimeters of change. I mean, that's like going back to square one. You might as well never have had braces because the tongue just pushed its way back through the teeth and created either an open anterior bite, lateral bite, wherever that tongue wanted to push, it did. The experimental group only had 0.5 millimeters. I'm going to wager a guess that if you talk to an orthodontist out there, they would say that many of their patients without tongue thrust, just by virtue of having orthodontia, might have 0.5 millimeters of change. So it really is so glaring to me what a difference it made. And when I work with the orthodontists that I work with, and I remind them of this article, A, they've already read it, and that's why they're so happy when I walk in their door. And two, they're so grateful that they have a place to refer their patients to know that they're going to get long-term success. Because what happens is when somebody has a tongue thrust, they get orthodontia. Within a few months, they start to see relapse, and they do one of two things. They're either disappointed in themselves because they didn't wear their retainer and they think that they fault themselves, or two, they say that orthodontist sucked and they blame the orthodontist for having poor treatment plan. But the truth is that the problem lied within their own mouth, within the muscle of their tongue. So when I have my team of orthodontists, and you will get your team together too, they are grateful to have somebody to refer to so that they can have longer term success with the orthodontia that they provide. So go get that article, read it. You will, if you don't believe it already, you'll believe it more, and so will your orthodontists. So let's talk about what Simon Says is all about, and let's talk about the myofunctional therapy programs that I've developed. I want to mention that for 20 years and still today, I did predominantly neuro rehabilitation. I worked with stroke and brain injury patients in pretty much every kind of facility you can imagine. I did acute care hospitals, subacute rehab. I didn't do home health, but I did do private practice. So that was what I did for the majority of my practice early in my profession. I spoke at ASHA about book clubs that I had developed, and that will always be, close to my heart. And about 10 years ago, I had a set of braces on as an adult because some of my teeth had shifted, not from a tongue thrust, I must say. But I got braces on, and I turned to my orthodontist because there was a kid sitting next to me with a horrible, horrible tongue thrust. And I said, "What do you do with your tongue thrusters?" And his answer changed the trajectory of my profession and my career from that day forward. He said, "I send them to their school speech therapist." And my response was, they don't touch them. You know that a tongue thrust would not academically or educationally impact most individuals, and so therefore they're not getting picked up. He's like, "Well, if you know what you're doing, I'll send them to you." And I was like, back in grad school, I had like a one-day seminar where I got 6 pieces of paper with some exercise suggestions, but I knew that that was not going to be enough. So I did a little research, and I attended a 4-day seminar up in New Jersey, hosted by Barbara Green and Joy Moeller. I will always be indebted to them. They were fantabulous. They were awesome. I learned so much. And within the first, 4 hours of being there and the first day, I realized it was the perfect fit for me. But after the 4 days, I walked away not knowing how in Lord's name to make a profession out of it or how to make a business out of it. I knew I wanted to try to integrate it into my practice, but I was not a business person innately. So I loved helping people and I loved making a difference in their lives. And I knew that these therapeutic techniques could, but I did not know how to make a business out of it. So I came home and I spent some time trying to make the programs my own, trying to brand them with my Simon Says take, and name them things that I believed in and tweak some of the things to make it more my own. And 9-10 years later, we have both Thumbs Up and Tongue Tips. So Thumbs Up is a thumb sucking elimination program. It is so very fun. It is one of the most rewarding things that I do in my practice. I get to work with children and adolescents, believe it or not, that have prolonged thumb or finger sucking habits. And I help them and empower them to stop in a really, really positive way. I don't know if some of you have heard about my comic book that we just had come out, but I want you to get as excited as I am about this amazing comic book. that Andre, he literally took everything that was in my brain, all the like ideas and thoughts and stories, and he like made them come to life. Because the Thumbs Up program is about empowering children. And I have this premise or this idea that children need to become their own superhero. And this comic is all about teaching them how to become their own superhero. It's so cool. We're going to have a series of 4 comic books that you can use with your patients. One for thumb sucking, one for finger sucking, one for nail biting, one for tongue chewing, and one for pacifier use. And you're going to get to use them with your clients. And they're going to be an integral part of your training. So fun. Thanks, Andre. So Thumbs Up is the thumb sucking elimination program. Tongue Tips is a tongue thrust remediation program. So for all those myofunctional disorders that you saw, thanks, Angelo. It is a 12-session, but that's spread out over 4 to 6 months, program that helps remediate a tongue thrust, retrain, correct positioning of the tongue at rest, during speech, and during swallowing. Here's Thumbs Up, a great couple families that have worked hard. It's 30 days. It's all behavioral modification. It's incredibly empowering, and all these kids succeed. So for my program, I charge $400 for the 30-day program. I meet with them 3 times. And if you've done everything that I've asked of you and you still do not have success, I will give you, half your money back, because I never went into this to take people's money without success. And I have to say, I've only had to give back money 2 times in 9 years. Everybody succeeds. They just do great unless they're not doing what I've asked of them. So it's so fun. It's a great program. The second program is Tongue Tips. And I think some of you guys have ordered or received. You might have a little mini manual, a Tongue Tips manual that gives you a little synopsis of what a tongue thrust is, why you should be concerned, and what effect it can have in the long term. And then it even talks in detail about the 12-session program, taking you through each different session and the exercises that you might see or use. It also describes the exercises and talks about typical speech sound errors that you might see, and the ladder that you'll use in helping them improve. Tongue Tips, like I said, it's 12 sessions. I see them for 8 weeks consecutively, 2 sessions bi-weekly, and then the last 2 sessions are once a month, because I want long-term change. I want to have a longer-term success over time. I don't want to just teach you a new swallow and send you on your way. I want to actually strengthen the musculature of your lips, your tongue, and your facial muscles. I want to teach you a correct swallow. I want to make sure your speech is correct. And then I want to do that over time so that I know when you come 4 months later, you're done. And then I give you a maintenance program to make sure it holds. So these questions are actually, oh, there's Alina, by the way. There's my little friend who had her frenulum clipped. She's doing amazing. If any of you come to the conference in October, you'll get to meet her. She's amazing, and her mom's even cooler. But these are questions that I present to ENTs, pediatricians, and orthodontists when I go talk to them. I ask them questions like, what do you do with your patients that are mouth breathers? What do you do for the orthodontist? Are you using cribs? Are you using rakes? These are appliances that orthodontists put in that have sharp prongs or spikes that go down into the mouth. I mean, can you imagine a little 8-year-old kid who's getting expansion of their palate, which is painful enough as it is, and then they have sharp spikes coming down in the middle of their mouth? This is how they talk when they have a crib or a rake in. I'm literally not kidding. That's what they sound like. I'm not exaggerating. I have it down to a science. But they can't speak. They can't correct their speech. And they certainly can't learn correct posture of the tongue with these sharp things in. And guess what happens? The rake, the crib comes out, and the tongue goes right back to where it was before, which is to the teeth. So you got to train proper positioning, not just give it a new barrier to bounce off of. I ask my doctors what they do with their thumb or their finger suckers. I ask if any of their patients have had a relapse. I ask like I did with the orthodontist, Dr. Sheehan, that I worked with, what they recommend for their tongue thrust patients. You'd be amazed. Most of them either don't do anything. They say they give up on the tongue, or they refer them to their school speech therapist who doesn't touch them. So think about these questions. These are questions for professionals and questions for yourself. Now let's get to an important piece of information, which is that I want you guys to think about myofunctional therapy as a team approach. I want you to think about it in terms of you being one piece of the puzzle. You're a speech therapist, especially in myofunctional therapy. You are going to work with orthodontists, dentists, dental hygienists, ENTs, oral surgeons, pediatricians, and osteopaths. And the trick and the key is to align yourself with other professionals that want to work with you, that believe in myofunctional therapy, and they get this overall premise of the team approach. I have gone to orthodontists, and I come in and I give my whole spiel, my whole synopsis. I show them the PowerPoint. I show them my successes. I show them pictures of patients that have started from one place and gone to another. And they either hug me and jump up and down and get so excited and start referring me like 10 patients a week because they've been waiting for someone to walk through their door. Or two, they look at you and they say, thank you very much, but my braces will do everything. And that's when you know that they're not somebody that you want on your team, that they think that they can change everything, and they might not be a fit for working with you. Though you'd be amazed when they get that really bad case, you're getting sent that client, just telling you. But finding your correct professionals is super important. I have sent kids for lingualfrenulum clippings, and they've gone to see an oral surgeon who did the procedure. I had never met them, but they didn't go far enough down, and they're still totally restricted lingually. So you want to make sure that you meet with your oral surgeons and with your ENTs. You watch them do the procedures to see exactly how they're doing it and what the end result is, so that you can play a role in preventing any scar tissue from building up and then having any relapse. So create your interdisciplinary team. Angela's helping me. Oh, that's it. Okay, great. So that's the end of my PowerPoint presentation. Let's see if I can go back to the other screen so at least we can talk.
Angela asked, well, you have two questions. Nicole asked, where is the workshop in October? I responded saying it was in Baltimore, Maryland, but if you want to go a little bit.
Yeah, let me tell you a little bit about that. That's great.
The second one is, Angela asked, how do you start meeting these people? Just go to their appointments, question mark. So if you want to do Angela's first one today.
Angela's asking, how do I meet the patients? How do I get the referrals?
How do you start meeting these people? Just go to the appointments, question mark.
Okay, so Angela, great question. When I first started out, I told you I left the seminar that I went to in New Jersey, and I was a little bit at a loss because I knew that this was a niche market for me. I knew it was the right fit, but I didn't know how to turn it into a business, right?
How do you form a team?
So, how do I form a team? So not necessarily the patients themselves. Okay, so the best way to make a team is to take the PowerPoint presentation that I have that I'm going to share with you, that I'm going to teach you in the seminar, and then you're going to go to an orthodontist and show them your PowerPoint, do your educational piece, and ask them the questions that I showed you. What do you do with your tongue thrust patients? Have you had any patients have relapse? And then they're going to start referring you their tough cases that they've been struggling with. So that's how you make your team. You want to look in your local community. I mean, if you have children, go to your pediatrician. If your children have had braces, go to your orthodontist. Start getting the word on the street. There's literally an orthodontist. I don't know where you are, Angela, like where you're located, but there's an orthodontist on every corner out here in Rockville, Bethesda, Potomac, and in Maryland. I can guarantee you there's an orthodontist everywhere that you live. And you just need to align yourself with the one that believes in myofunctional therapy. So that answers your question.
She has one more question.
Oh, good. I love it. I love it, Angela. Keep asking.
Do you call and say you want to give a presentation?
So what I do is I call it a lunch and learn, and they get them all the time. So all kinds of medical and health professionals go into doctors' offices and dentists, and they want to share their Sonicare product. They want to share their new fluoride rinse. They want to share their new dental floss. And so we're just another practitioner that wants to go in and share our expertise. And we want to have a lunch and learn. I bring lunch if I can afford to do that, if it's not too big of an office. I'll go in and I'll bring lunch, or even if it's just cookies and coffee for the staff, and I'll do my PowerPoint to whoever's available. And I bring my pamphlets. So I have marketing tools that you can have too once you come to my seminar. I have created so again, when I went to that seminar in Jersey, I left and I was like, well, I don't even know how to market myself. So I created, this is both thumbs up. I created tongue tips and thumbs up marketing materials. And inside, it tells a little bit about what thumbs up the program is. And then it tells a little bit about me, and it has a little game at the bottom. For tongue tips, it's the same thing. It talks about what a tongue thrust is, shows my information, and has a little game at the bottom. Now, if you come to my seminar, which I'll talk about in October, and you sign up to be a part of my inner circle, you can actually get all these materials, and they'll have my team will help you order them with your information on the back. Because I spent 9 years trying to get all this together and organize it. That is what I want to be seamless for you. You guys are all great practitioners. You're great speech therapists. You're good at what you do. All right. And all I want to do is teach you a little expertise about myofunctional therapy, this exciting niche market within our field. And we're already prepared to do it, right? Under ASHA's codes, we are already deemed appropriate providers of myofunctional therapy. Okay. There are associations out there that will also have dental hygienists, and they're trying to give you certification in myofunctional therapy. We don't need it. We're speech therapists. Speech therapists are licensed and deemed appropriate to provide myofunctional therapy, and with the speech therapy involved, which a lot of people can't do. So these marketing materials, they're all just waiting for you. They're available for you. Okay, let me talk about the seminar. Please join me. This is just a little taste, okay? This is like a 1 hour little taste of myofunctional therapy. But in the 3-day event, you are going to receive information on what myofunctional disorders are, okay? So a little bit more detail about each different myofunctional disorder that you might see in your practice. I want to teach you about the myofunctional therapy approach. I want to give you my cookbook, okay? You will receive this binder. And in this binder, it has all the materials, including the comic book that you will need. It has the PowerPoint. It has some research studies. It has all my intake and evaluation and paperwork. And then, it's the cookbook, all right? It is session by session, all the therapeutic exercises that you're gonna need. And you're literally just gonna hand your patients this cookbook, and you're going to do it along with them and teach it to them. And then I have all kinds of extra forms that we use for maintenance or for swallowing. And you get this book. This is yours from the 3-day conference. But in this program, this 3-day program, you will learn how to implement all the aspects of the programs. And the best part is you're going to also get the business acumen. So because I left my program feeling a little cited on what I needed to do to start my own business, you can see I have a team of professionals. They're actually sitting with me at 8 o'clock, 9 o'clock at night. God bless them. And they are here ready to help you with your marketing, to help you with your materials, to help you set up your Square account so that you can charge people and get paid on the spot. And they're going to help you with your scheduling system. So these are the things that I want to help you learn and implement from that 3-day program. It's going to take place October 7th through 9th. It's Columbus Day weekend. Is that right? 6th through 8th. 7th through 9th. Sorry, I've had like 10 different dates on the calendar. It's the The 7th through the 9th, Columbus Day weekend. It's going to be in Baltimore, Maryland. I hope that you will join me. I'm going to have clients coming in that you guys can do evaluations on. I'm going to have clients coming in that you can practice some of your therapy on. I'm going to have interns there that you can practice on. You'll get all the materials that you need and the resources so that you can literally leave and start your own practice. Oh, yes. Okay, so typically this program would be $3,000 for the 3-day seminar, but because you joined us on this webinar, thank you for joining us so late at night, Julie is actually for the next 30 minutes going to post a registration for $1,500 because I so appreciate your time. You've already gotten a little snippet of what myofunctional therapy is, and hopefully you're as excited about it as I am to continue teaching it, and you will see a link at the bottom of the page in Webinar Jam that can take you to a link where you can register for $1,500 for that 3-day. And I hope that you'll join me. It's going to be a lot of fun.
You have 2 questions.
Okay, I have 2 questions.
Gloria asks, are your programs successful in adults?
100%. I love working with adults. So I started, like I told you, in stroke and brain injury rehab. I worked only with adults. And I find that the adults actually have faster success even than the kids. So I like to start working with kids when they're like ages like 8 and up, although the thumbsuckers can be around 5 and up. But the adults, they just get it. Once they learn where their tongue should be resting at rest and during swallowing, they just take off. You know, there's no bribery. There's no trying to convince them that they need to do this work. They've been dealing with TMJ issues. They've had braces on 3 times. They've maybe had jaw surgery, and they are desperate to make a change. And unfortunately, every time that they've had braces or had an issue, they've been waiting for the person, or they've heard it before and they haven't followed up on it, that says, you had a tongue thrust and you need to correct the muscle of your tongue, or nothing else in your jaw and your face will hold. And we become the solution. I mean, we really make such a difference in their lives. And that's why aligning yourself with orthodontists and oral surgeons is so, so critical, because people are going to be lining up at your door. I work 2 days a week. I used to work in the hospitals every weekend, every holiday. I was missing time with my kids. And now I do solely myofunctional therapy. I work 2 days a week. I get to do webinars from my house in the evening. And now I get to train other speech therapists about this niche market. And it's so, so very fun. So I make more money now working 2 days a week than I ever did working my 5 days a week and weekends and holidays.
Gabriel asks, is there any chance it will be recorded and can be viewed on demand after the fact for the event?
I don't think so. We're not going to record this 3-day conference. I'm anticipating in the future that I'll be speaking at ASHA, and
it's such a personal event.
Yeah, it's really quite a personal event. There's so much one-on-one contact, a lot of hands-on experience, that I don't really feel like you could get as much out of it if it was recorded and you just, you know, took a stab at it. Jennifer's asking, where can she find the link for the mini handbook? Julie is sending it to you now. Will the 3-day conference be at other locations in the future? Yeah, sure. We're going to start with Baltimore just because it's really easily accessible by plane, by train, by bus, and only 45 minutes away from my home. But we will likely have other locations. Where are you located, Angela?
It'll take 30 seconds for her to answer.
Oh, okay. I want to show you guys that with all those exercises, the cookbook, we put together some amazing materials that you'll receive at the conference. Aside from the binder and the comic book and your marketing materials, you are going to get a little spiral of all the different exercises where it says the exercise and it gives you a description. And we've created this amazing system where there's an icon at the top that tells you whether that exercise is working on the lips, on a swallow, on speech, etc., so that you have that at your fingertips.
Also videos.
Oh, yes. And Angelo, this guy right here who's amazing, he helped me create videos of every exercise so that once you attend the conference, you actually have access to all those videos. So when you teach your students, your clients, how to do these exercises, if they forget, then they can click on the link. You can send them the video, and they have access to it, so that they never need to, like, you know, call you 500 times or show up the next week having not known what to do. It looks like Angela's in Utah. I love Utah. Let's go, baby. I'll come out to Utah and go skiing and teach you guys some myofunctional therapy. I do want to mention that there are, you know, I got trained by, you're going to hear words like IAOM and AOMT. Those are both associations that talk about myofunctional therapy. They teach myofunctional therapy. The AOMT does a lot of international travel and education. And the IAOM, both is comprised of a combination of mostly dental hygienists and a very few small speech therapists. And they, again, try to get you certified for much, much money to have your certification of orofacial myology. As speech therapists, we do not need that. We can just take a 3-day conference and just get started and just start your practice. I've already trained a bunch of speech therapists. I have, you know, speech therapists that are already working, creating their own team of orthodontists, even here in my own area. And I never feel like we're competing with one another, because there's plenty of business to go around. And I have another friend, Deanna, who is starting, and she's going to kill it. She's just going to do great. I'm so excited for her. She's going to be really, really good at what she does. So thank you guys so much. Any other last minute questions? If you have questions afterwards, feel free to email me or Julie. And Julie's email is julie@simonsayspeech.com. And we're happy to answer anything. But thanks so much for joining me. I love sharing and talking about myofunctional therapy. I'm super excited to teach anybody who wants to learn about this niche market. Please join me in October. I would love to have you. Take care. Thanks, Angelo.